President, Vice President, members of Council, past presidents, fellows members, faculty and distinguished guests, it's a real pleasure to welcome you all to the 101st Abraham Colles Lecture. It gives me great pleasure to invite Council member Mr. David Moore to come forward to introduce this year's speaker, Professor Ewen Harrison, Professor of Surgery and Data Science at Edinburgh University.
Good afternoon. The Abraham Colles Lecture is the most prestigious named college lecture, and this year, as you've heard, is the 101st lecture. Abraham Colles was a former student, professor, and president of RCSI, and to this day, his eponymous fracture is known to every medical practitioner. This annual lecture celebrates leadership, innovation and excellence in surgery, and tonight's speaker embodies all three. Professor Ewen Harrison is Professor of Surgery and Data Science at the University of Edinburgh and a consultant hepatobiliary surgery at the Royal Infirmary of Edinburgh. He is internationally recognised for pioneering data-driven approaches to improving surgical outcomes, leading the Surgical and Critical Care Informatics Group, and co-directing the Centre for Medical Informatics at the Usher Institute. His work spans artificial intelligence, machine learning, global surgery, clinical trials, and wearable sensing, all with a single focus to deliver better, safer care for patients. He's also the driving force behind global research collaborations, including the Global Surge and COVID Serve initiatives, which together have involved more than 15,000 collaborators in over 100 countries and hold the Guinness World Record as the world's largest scientific collaboration. His leadership in surgical data science has been recognised with election to the Academy of Medical Sciences and the Royal Society of Edinburgh, as well as an OBE for his contributions during the COVID-19 pandemic. Professor Harrison will deliver a lecture titled Harnessing Artificial Intelligence to Improve Surgical Care. At a moment when AI is reshaping every aspect of healthcare, his insight, experience, and global perspective could not be timelier. Please join me in warmly welcoming Professor Ewen Harrison to deliver the 101st Abraham Colles Lecture.
Well, President, office bearers, fellows, members of the Royal College of Surgeons of Ireland, honoured guests, what a pleasure and an honour to be in Dublin today to give this 101st Abraham Colles Lecture. Thank you for the invitation. Thank you for IFA and all of the organisation. We've been looked after very well. It's a delight to be doing this with my wife Livy and Callan, aged 11, and Finn, aged 9, who are now really embarrassed in the audience. This is the first time they've been to anything like this. So I don't have any conflicts of interest for this talk. So I'd like to start on the 6th of September 1939, 3 days after the start of World War II. Along the English coast, a new technology was being tested, radar. That morning, a signal was interpreted as enemy aircraft. Spitfires and Hurricanes were scrambled from 2 RAF bases to intercept. But there was no enemy. The signal had been misinterpreted, and in the confusion that followed, British pilots shot down British planes. One pilot, Montague Hulton Harrop, was killed, a friendly fire death that never should have happened. Radar would go on to change the war, but not because the sensor was in some sense magical. It worked because of interpretation of a signal, because of the procedures that were placed around about that interpretation, and trust caught up with the technology. And that's how I would like to frame today's talk. And it's really clear the parallels that exist between the development of radar in the 1920s and 30s and where we are with artificial intelligence in the 2020s. Artificial intelligence is extending our abilities to sense, to perceive. As you've heard in the fantastic sessions that have come before this, it is improving prediction. It is allowing better or more reliable decision support in combination with patients and their families. And it's increasing productivity across domains of society, including, and maybe in particular, in healthcare. But this is what is important for you in this audience, and for me, if you like, as a jobbing surgeon. Patient outcomes will depend on the interpretation of these models. They will depend on the integration of these technologies into health system pathways in a much more efficient way than has been done up until now. And oversight and monitoring incumbent on the safe deployment of this technology is required for safe AI practice, if you like. And all of that is much more important than what seems to be almost the sole focus of many AI-orientated developers today, which is model accuracy and model calibration. So I'll illustrate this with 3 programs of work. These programs of work were all funded by Wellcome Leap, a fantastic set of programs across novel technologies. But they're notable, I think, because they have been deployed globally. So this is technology which has been deployed and tested across the global south as well as the global north, across themes of perception, so computer vision, both in theatre and education, through the CAMOS projects, prediction, and I'll tell you about the EMU's programme of work, wearables after surgery for the early detection of deterioration, and the large language models that we've heard about already today, trying to improve the productivity and the business of healthcare through the procedural LM programme. So in a sense, this has until recently been the state of the art. And it's no longer the state of the art, despite being put together in 2022, 2023. And you've maybe seen this video before. It's by Pietro Mascagni and Nicholas Padoy, collaborators of us in Strasbourg. And it shows a cholecystectomy, a laparoscopic cholecystectomy. But it illustrates 3 really important things about healthcare AI. So the first is that this is in real time. This is an AI model which is being delivered on a surgical procedure currently being performed. So much of the work that we see being done at the moment is on highly curated video, often video data sets, which have been optimized for this. Number 2 is that in unreadable text at the top left-hand corner is a phase detection of the procedure. So the underlying artificial intelligence model can detect which part of the procedure is being performed, whether the ports are being put in, whether a callous triangle is being dissected, etc. And number 3 is the AI overlay of the organs, the gallbladder in green, the cystic artery in red, the cystic duct in brown. A lot of work has been done with these overlays, and it's not particularly helpful. It's not really going to help a surgeon at the moment to have the gallbladder coloured in green. I think we would all agree with that. But the yellow area at the back is probably beneficial, the critical view of safety. So we've known for, 30 years that by creating that space, we are able to reduce the risk of bile duct injury. And that principle of building into models things that we as surgeons know are useful is absolutely crucial. But how do we go from this to something that can be actually used in practice? The theme of this talk about integration of these sort of technologies. Well, the next step from Pietro, Nick, and the team is really fantastic. This is a critical view of safety interface, which would be on the screen during the procedure. In the top right-hand corner there, you can see 3 little icons. One is for 2 structures going into the gallbladder, 2 and no more than 2. The triangle is clearance of the hepatocystic triangle. The circle is clearance of the cystic plate. And you can see there's little green and amber indicators for how confident the underlying AI model is in whether the critical view of safety has been achieved. So a lot of qualitative work has gone into developing this interface, and this is now ready for testing in clinical practice. All of this is important, I think, because these sort of problems are not problems of the global north. They're problems of individuals treating surgical disease about the world. And this was a programme of work we have done, the Global Surge, the 4th of the Global Surge programmes, which was into cholecystectomy. So global practice of cholecystectomy. Thank you to anyone in the audience who contributed to Ireland data. There was over 200 patients from Ireland contributing into this. So 53,000 patients across 1,200 hospitals, 109 countries, all prospectively collected at the bedside by individuals looking after these patients. 10,500 individuals contributing to these data. As you might expect, bile duct injury 3 times more common when the critical view of safety has not been documented as part of common practice within that hospital. But probably more importantly, that simulation and training facilities, when present in that hospital, are associated with fewer complications. And that study has been published just in the last month or so in Lancet Global Health. And I hope could be a kind of call to arms around simulation, around training in global terms, thinking about how we really do this, how we scale this globally rather than concentrating on what is being done in the global north. But this is expensive, both in terms of the infrastructure and in the time individuals, trainers have to give to this. So the next step of this project was to deploy basic laparoscopic training programs worldwide. And this was specifically not robotic. This program of work excluded robotic surgery because of the perception of the time it will take for global south countries to get robotic surgery programs up and running. So 530 participants, over 14,000 videos brought in on a laparoscopic training program augmented with artificial intelligence. And the artificial intelligence for that was instrument tracking. So can we help the trainee, can we help the trainers by trying to get that individual more information about where they are in that early years technical components of manipulation of laparoscopic instruments. And the instrument tracking, which you'll hear a lot about in these sort of meetings, is good to a point. It is good in terms of flow, in terms of handling of instruments, a couple of the domains that are measured. But as soon as you get more subtle than that, even just handling of tissue, if you like, then it starts to fall off. So what is really needed is much more bespoke models that describe a trainee's particular technical competence at that level in time. And so here's an example of that, which was a collaboration with Scilytics, a company who do computer vision. And this is one of this is one of the laparoscopic box trainer programs, balancing dice on top of each other, much harder than you might think it is. I think the kids have had a go when we did this in the primary school. And under the videos there's a laparoscopic there's a computer vision model identifying particular components of that exercise, rearrangement of the dice, transporting of the dice, etc. And by doing these bespoke models, we can get much more accurate prediction of the human provided label for those individuals. But the next step is to think beyond the box trainer and beyond the simple laparoscopic training procedures itself. This was a collaboration as part of Welcome Leap with a Dutch company called Grendel on the Laptitude platform, which I understand was presented in Dublin about a year ago, an early version of it. So this is on a laptop. It's gamification. It's a game with a console, as you can see there. It's relatively cheap. The console is less than €500. There is, as you might imagine, a license to continue to use the software, but it's been developed specifically thinking about broad scalability rather than small, expensive deployment. And you might like this, you might hate it. I think I'm in the middle. We're just finishing a randomized control trial at the moment of the box trainer versus this Laptitude. It's been run in India, in Nigeria, and in Guatemala. 160 box trainer naive individuals, most of whom are medical students. And the message that's likely going to come out of that trial is that they are complementary to each other, but one does not replace the other. And one of the reasons for that is Laptitude, that platform, has no haptics. So when, as similar to the robot or generations of the robot up until now, you cannot feel what you are doing with the instrument in the way that you can with the box trainer. And thinking about progressing beyond that to actual procedural training, there's a number of procedures ready to go. Here's cholecystectomy. What do you think about this? Is it useful? It's probably not that useful for learning how to do the technical part of laparoscopic cholecystectomy. But in those early years of training, when you're learning the steps of the procedure, the pitfalls of the procedure, the safety, maybe building critical view of safety into that, etc., it probably is an important part of that. What about, though, the link between what gets done in the simulation or the out of operating theatre setting and the theatre itself? Can we tell whether the trainee is at a level where they could be doing the procedure, could be leading the procedure? So the final extension to this little bit of CAMELS is relating AI-based assessment of box trainer technical performance with what that trainee does in the operating theatre. So simultaneous collection of those data which are quite hard to come by and which are certainly hard to get across settings. So again, this is across 7 different countries. And nicely, I think you can see close alignment of technical domains. So the x-axis of that plot is operating theatre, the y-axis is in the simulation lab. The 2 boxes on the left-hand side are technical domains using the simple score. But on the right-hand side, NOTs, as in non-operative skills, such as situational awareness, decisions, communication, teams, are, I think, pleasingly not well captured by the video. And, as we heard earlier, there's a lot of discussion as to what can you actually determine from the video alone. And I think, personally, it's only going to be a small component of that broader training paradigm. A change of theme then. The EMU's project was around prediction, around decision support. In our 2001 work, we showed that 40% of the variation in death following complications occurs at the health system level. What does that mean? Well, it means that patient characteristics, disease characteristics are not predictive of whether a patient dies or not. And this contributes to this principle that you're all aware of failure to rescue, so that a high-performing health system will be able to recognise and act on a complication when it occurs in order to reduce the chance of that individual dying as a result of that complication. A really important principle which underlies much of perioperative surgical care. And it's an interesting question as to whether the wearable technologies, and in particular continuous monitoring, can improve capacity to rescue, can improve the ability of a health system to prevent that individual from dying. So here we took a sensor. These are SIBO sensors, which is a Northwestern University spin-out. The sensor gets put on the chest. There's a sensor in the finger. It does all of the physiological metrics that you might guess. They get put on prior to surgery and are followed through the surgical procedure until the patient is discharged, or from the point of view of this study, 10 days after that, whatever comes first. This part of the study, that data was not fed back to clinical teams. So the data is just being recorded. So remember, this is being deployed again across 7 low and middle income countries, as well as the US, the UK, and in Australasia. So the real challenge around about this, I think, is not about the predictive algorithms. They will all come. It's how does this get deployed into the health system. So here's one of the patients from Edinburgh. They'd undergone an Ivor Lewis, so to resect a cancer in the gullet, as you know, and had an anastomotic leak. And one of the real questions around about the continuous monitoring is when you put it up against these early warning scores, so the National Early Warning Score 2 or similar locally adopted scores in order to identify patients who are deteriorating. Of course, they are, in most of their incarnations, simply static. They're looking at physiological metrics at that point in time and determining how far out of physiological norms those parameters are. They don't take into account what's been happening over the last 2 or 4 or 8 hours or the last 2 years. They don't take into account whether a patient is diabetic or hypertensive or not. And they don't predict what might happen in the future. So real opportunities to be much, much better about using all of the information that you've heard about in the other talks in order to think about this more carefully. And even with relatively simple approaches to continuous monitoring and a continuous news score, the SAFE score, we've dubbed it. In this particular patient, we saw a 40-hour difference between the red flag on the continuous monitors versus the news score becoming abnormal on the squares there, which are the nurse-collected data. And that's without a significant increase in false alarms, because of course you can find anything early enough if the alarms are raging all the time, and that is the real that's the real challenge. So taking these physiological measures and combining them with patient and disease parameters in order to really think about what is going to be happening, what's the risk over the next 6 hours of this patient bleeding, of them developing sepsis, of them having a myocardial infarction. So we've got 1,400 patients in this, 550 million heartbeats is a statistic I quite like. 20 years of sensor data. All of the data I show you today will be made freely available to anyone working in this area who wishes to use it. And using these transformer models, so this is the underlying technology that allows ChatGPT and similar large language models to work, we can get real improvements in these numerically orientated prediction models. So the transformer approach, which is really driven this change in the delivery of artificial intelligence that we're seeing in the moment can work lots of different ways. So lots to see here. But for you and me, thinking about how we move this technology forward, it's all about integration. And so we had the nurses, this is nurses from Nigeria and India and Edinburgh, around the table with the technology company on day one. Not 2 years later, here we've made this for you, do you want to try it in your hospital? The individuals looking after the patients saying, see your sticky plaster that you're using to stick the chest sensor on, that's not going to work in our hot, dusty environment. And the technology companies love this. They need to be told that they love it, but they love it, and it was changed for the better. And so my last little vignette is around productivity and these large language models. So the ChatGPT, which is changing the world, and it really is changing the world in a way that the dawn of the internet, if you like, did in the early 90s when I was starting in university. And some have even said it is akin to the discovery of electricity and Edison's light bulb. That is, I believe that is the predicted disruption to all of our lives, across many of the domains of life that we live. And we've heard about ambient. I've got a bit to say about it, but if you haven't tried it, I put Heidi up here as an example because it's free. So you can try this out on your mobile phone, this evening if you like. And so this was me and one of the medical students doing A&E, an emergency department presentation with an appendicitis. And it will write an admission note, and the admission note takes the lay terms. I've got high blood pressure, and I'm on a drug for that. It takes those and converts them almost perfectly into what you would write in the notes. But it will also extract other data, like I mentioned, hypertension, and write you a prescription chart. It will write you the investigation request for ultrasound. It will write you a post-operative care plan, all of which can be made bespoke to your local health system. But, the first two randomized controlled trials of the ambient technologies were published as a pair in the New England Journal AI just in December there. And, despite what you've heard here, it's not all happiness. The Microsoft product, for instance, did not reduce time in notes, which is the number one metric that these technologies will promise. They are here to stay. There's over 30 companies now in this area. They are amazing. They will change the world in which we live, but we need careful evaluation and really thinking about how they are brought into our hospital systems to ensure that they're actually working well, rather than just I was going to say believing the marketing hype. I don't want to be negative about it, but we need to be assessing them ourselves in our environment. And that productivity will extend, so I've got a couple of slides on what's now been called guided autonomy. So to what extent do we let the reins off the underlying model in order for it to do something useful for us? And agentic or agent-based systems are where the large language model is able to go into different systems and pull information back. And this is now infrastructure. This is now being deployed in clinical practice. Here's an example. What's the calcium level of this patient? If it's low, give the patient some calcium. And so the system is able to go into the EHR, pull out the results, go into the patient history, understand a bit about them, go into guidelines, calculators, etc., and can conclude the patient's calcium is X. So I've placed a draft order for some IV calcium. And the discussion that was had earlier about, well, what if the model is wrong and the doctor's right? Or what if the doctor's right and the model's wrong is right in the money, because we're really not clear as to how that dissonance is going to be handled at the moment. And doctors will be pushed into doing things that they wouldn't necessarily have been pushed into doing, particularly when we're using models that have been trained predominantly in the US, which is a completely different reimbursement model, and where, for instance, the prescription of high-value pharmaceuticals may be baked into these sort of training models. Vision language models are where the computer vision that we've heard about earlier and the ChatGPT, that's where that meets. There's lots of technologies that this will be the interface that we as doctors use. For instance, looking at a chest X-ray, what are the findings on this image? The nasogastric tube is adequately in position, etc. But one thing the large language models are going to be able to do is allow us to interact with the data that's being collected on a day-to-day basis in a much more real-time manner. In the difficult Whipple procedure I do on a Friday, Alexa, as the boys would say, accounting for intraoperative data, what's the risk of complications and death at 30 days and 1 year overall survival for this patient, real-time updates, digital twinning for the patient that you've got in front of you. In the 78-year-old patient undergoing a Whipple procedure, accounting for intraoperative bleeding and a 90% chance of local invasion, the 30-day complication is X. Consider stopping maybe or moving to a palliative basis. But these models are brittle, and this was very nicely illustrated in the last few months. So out-of-the-box general foundation models are quite good at interpreting histology slides. So they get around 50% of the time an ovarian cancer correct versus a prostate cancer correct if you feed them the H&E section for that particular cancer. Except if you hide a little logo on the ovarian cancer slide saying prostate cancer centre, or a little logo on the prostate cancer slide saying ovarian cancer centre, when it gets it completely wrong. It goes from 50% to 0%. And it's these sorts of things that are, again, baked into this underlying data. So in September 2023, I asked ChatGPT, please provide a photo of a female surgeon and a male nurse in a hospital. The surgeon is reviewing the notes. The nurse is holding the tray of medical supplies. And as you can maybe see, because the internet has not seen enough women surgeons, the female surgeon, the female role is that of the nurse, and the male role is that of the surgeon, illustrating inherent bias in the underlying data. Doing that again in June last year, it did get it right. And it gets it right because of filters that are now put on the beginning and the end of these models in general, rather than the model itself necessarily changing. And that's illustrated by going to Sora, which is the new OpenAI video app, providing it with the same prompt. And it's back to the female holding, the female in the nursing role, rather than the male in the nursing role. So inherent bias in underlying data causing, which we need to be aware of. I don't know if you've seen this. So this is my last video slide, guided autonomy. So this is by Axel Krieger's group, who is in the Johns Hopkins. This is on the Da Vinci research kit, and this is a pig model of cholecystectomy, and this is completely autonomous. There is no human control over what is being done here at all. There are high-level policies, as they call them, ChatGPT models saying clip and cut the two ducts, and then a lower-level model that guides where the surgical instruments go. So it is able to put a clip on the cystic duct above and below, put a clip on the cystic artery above and below. If it gets it wrong, as you can see here, if it takes the two structures in the clip, it is able to self-correct. So I used to do these sort of talks and say we're very far away from autonomous surgery in itself, and this has really made me stop and think. And whether we're going to be driving the robot up to a particular procedure, maybe like a particularly difficult anastomosis on a microscopic vessel, or closing the abdomen, certainly putting in cannulas and taking blood, there will be human oversight around about this, but it is not going to be as long as I think previously thought before the robot is able to do better than the human. So the theme of this talk is about interpretation, integration and oversight, and we've heard others this afternoon talk about human in the loop. Charlotta and I have written an editorial which will be out in the next few weeks, really challenging who is the human and where in the loop are they and what even is the loop. And there's a number of loops: a clinical loop, who sees the output of the model, how is it presented, what do they actually do with that? The governance loop, in a hospital, what is getting deployed, who is approving it, what evidence is required, what trade-offs are acceptable for the pros versus the cons. The learning loop, who monitors performance, detects drift, manages updates, who bears the ultimate responsibility when it gets it wrong. And taking a step back from that, we're into the world of responsible AI. AI which is anti-bias, which is transparent, which is explainable, which respects people's privacy, which is accountable and human-centric, which is robust, which is built on collaborative multi-stakeholder engagement across the world, not just within the Global South, and has proper societal impact that actually improves patient care. So what should the Royal College of Surgeons of Ireland be demanding? That the models that you are presented by companies are clear in the clinical decisions that they are seeking to influence, what pathway they are going to be built into, that there is local validation and monitoring. What actually do these models do in my own patient population? That there's defined accountability, that there's defined escalation pathways, that there's equity and bias checks across different subsections of the population, that evidence of impact on patient outcomes and, if appropriate, workflow has been demonstrated, not just that the performance metrics, the area under the receiver operating curve is sufficient or not. Harnessing AI to improve surgical care. What did we learn from the introduction of radar? That interpretation is a skill, it's a human task, and certainly at the moment it needs to be done and thought of by humans. That the technology itself is not enough, that integration with human expertise and health systems is paramount, and that effective oversight is required to build trust, transparency, validation, and safety. A couple of words on Abraham Colles. I'm really, really grateful and honoured to be invited to give this talk, named after the president of the Royal College of Surgeons of Ireland. I was really pleased to see that he'd studied in Edinburgh as well and received an MD in 1797, and then went on foot from Edinburgh to London, and probably made it there faster than you can get there on the train at the moment. A consummate anatomist, an expert in his time for many aspects of anatomy, but particularly the Colles fracture, considered ahead of its time, being published decades before X-rays came into use. And a quote I liked was, in his lectures, he was constantly watchful to prevent the influence of preconceived theories on his own and his pupils' judgment. And I think if he was here in these AI sessions at the moment, he would be very excited about the opportunities that could arise from them, but always be thinking about the evaluation and the relevance to the patients that he was looking after. Thank you very much.
So I found that, as I'm sure you all did, both fascinating, scary and exciting. So I would just like to thank Professor Harrison very much for a wonderful lecture, and to invite Professor McNamara to give him a memento of his talk today.
Once again, congratulations to Professor Harrison and a truly outstanding far-sighted talk. That concludes the formal proceedings of the Abraham Colles Lecture. This evening, we'll mark the launch of the Robotic and Technology Learning Village just above us, along with the new robotic surgery curriculum. followed by the 36th annual video surgery meeting. For those staying with us, refreshments will be available upstairs to encourage people to mix and to chat. And finally, I'd like to thank you all for joining us today, to extend our sincere thanks to our sponsors, exhibitors, the Robotic Village contributors, and also to thank you, our fellows and members, for your continued participation and engagement. If I could ask you all please to be upstanding for the outward procession.